So welcome friends, this is Dr. Vineet Sehgal and welcome to this YouTube live session on secondary glaucoma. Okay, so if you want to subscribe for the Unacademy NEET Plus program, this is my coupon code, that is Vineet Sehgal RPC AIMS 4415. You can just log in and with this referral code you can get the discount in the total package. Okay, so we would be starting with the secondary glaucomas. So either these are primary glaucomas like primary open angle glaucoma, primary angle closure glaucoma, or there are secondary glaucomas. Secondary glaucoma means that the main pathology lies somewhere else in the ocular system, and this basically gives rise to the glaucoma. So what are the different types of glaucoma? These can be pseudoexfoliation, uveitic glaucoma, neovascular glaucoma, steroid induced glaucoma, or lens induced glaucoma. So there are many types of secondary glaucomas, but out of them these ones are important for your exams. Okay, so we would discuss in brief various important points regarding these types of secondary glaucoma, and I have prepared the session in a T&D fashion. So I would be giving you first a question and then a very brief explanation. Okay, so let's start. So the first question for you is regarding pseudoexfoliation glaucoma. Not true regarding pseudoexfoliation glaucoma. Your options are asymmetric glaucoma, bullseye sign is seen, trans illumination defects are seen, weakened ciliary zonules. So try to answer in the comment section. So the answer here is C. Remember, the trans illumination defects are seen not in pseudoexfoliation glaucoma but in another type of secondary glaucoma, that is called pigment dispersion syndrome. Okay, so now you would ask me, sir, what are the signs of pseudoexfoliation glaucoma? So remember, pseudoexfoliation glaucoma is the most common type of secondary glaucoma. Okay, it is an asymmetrical glaucoma. So this means that the right eye has 0.8 or 0.9 cupping and the left eye may have a 0.6 cupping. So the gonioscopy that you do in these patients may reveal some fluffy whitish material on the angles of the eye as well. Okay, so that is basically responsible for the outflow obstruction. Initially it is an open angle glaucoma and slowly it creeps and becomes an angle closure glaucoma. Remember, this pseudo exfoliative material, the whitish fluffy material, can be seen on the pupillary margins, on the iris, on the angles of the eye, or on the lens capsule. Whenever it is seen on the lens capsule, it is called a bull's eye sign. Okay. Other important signs of pseudoexfoliation glaucoma is that you can get weakened zonules there. Because of this weakened zonules, your lens is basically sometimes subluxated. Okay, so pseudoexfoliation glaucoma can also be asked as a question that what are the associated signs of pseudoexfoliation glaucoma. So another associated sign which is very important is your subluxated lens. Okay, and then these pupil, because of the fluffy material on pupil and for the iris atrophy, these are the non-dilating or poorly dilating pupil. Okay, so these are some important points. Two more important points that I want to tell you, that Krukenberg spindles, where we have read about Krukenberg spindles, we have read it about Krukenberg spindles, that is the pigment lines deposit on the endothelial of the cornea. They can also be seen in pseudoexfoliation glaucoma. Okay, should we continue? Okay, the second question for you is, a patient presented with recurrent anterior uveitis with high intraocular pressure. Okay, there is recurrent anterior uveitis with high intraocular pressure. Which of the following drug is not used to decrease intraocular pressure? So I am asking about the drug that cannot be used. So your options are beta blockers, brinzolamide, acetazolamide, or PG analogs? So try to answer. So our answer here is D, that is the PG analogs. Remember, whenever you have a uveitic glaucoma, see here, there is a uveitis and there is a high intraocular pressure. Okay, so whenever there is a uveitic glaucoma, the two things that you do not have to use, one is a PG analog and the other drug is pilocarpine. Okay, so avoid these two drugs in any type of uveitic or inflammatory glaucoma, and the reason is because these two drugs can increase the inflammation. And remember why the glaucoma has occurred in these cases. Okay, because not because of any other pathology but because of uveitis. So uveitis causes pressure and this pressure can cause glaucoma. So you have to first, before decreasing the IOP, you have to see the reason why there is a uveitis. Treat uveitis, your pressure itself would come low. Okay, that's why even in the patients of hypertensive uveitis, we can use steroids, because what steroids do is steroids can cause decrease in the uveitis, and decreasing the amount of uveitis can itself cause decrease intraocular pressure. Remember, all the steroids all the time are not steroid responders. Anytime you use topical steroids, only 10% of them may get a steroid responsiveness. Okay, not all the patients. Okay, so remember what are the types of inflammatory glaucomas? These are the uveitic glaucomas. Okay, like hypertensive uveitis. There can be a pigment dispersion glaucoma. Okay, like I told you that trans illumination defects are seen in pigment dispersion glaucoma. Few important types of uveitis like Poshner-Skolsman syndrome and Fuchs heterochromic iridocyclitis. So there can be many types of inflammatory glaucoma. Out of these four are the most important ones. Okay. Now, few important points regarding the management of the patients of uveitic glaucoma. So first thing is avoid, as I told you, pilocarpine and PG analogs. You can use steroids to decrease the inflammation. Please use atropine or any cycloplegic. What atropine and cycloplegic does is it decreases the exudation from the vessels. Also, it prevents the formation of posterior synechias. Okay, so the posterior synechias are not formed. So there is no iris bombay there. So also the exudation is relieved, and the second thing is the spasm of iris is released, so there is less amount of pain. Okay, let's say in the uveitic glaucoma, if you have used a steroid and it has caused paradoxically more increase in the IOP, you can go for systemic steroids or soft steroids. What are soft steroids? We would see in the further slides. Okay, but remember, in any type of uveitic glaucoma, you have to go for either steroids or immunosuppressants. Okay, so there was a drug which was investigated for the use in the non-infectious uveitis for the steroid sparingness, and the drug was volcosporin. Okay, so this was an AIMS question. So which drug they have asked is used in the Luminate trial? So Luminate trial was a trial which was done to see the effect of volcosporin on non-infectious uveitis. Okay? Okay. The next question for you is, a patient presented with high intraocular pressure with following clinical picture. Okay, if you can see in this clinical picture, this is a pseudophakia and some red blood vessels seen over the iris. So which of the following is most probable diagnosis according to you? Your options are retinal detachment, acute uveitis, CRVO or CRAO. I repeat, the patient presented with high intraocular pressure with following clinical picture. Which of the following is most probable diagnosis? All of you try to answer. So, this is, I give you a hint, this is your neovascularization of iris you are seeing here. If you can see here, these are the blood vessels over the iris. These are the neovascularization of iris. Now, can you answer? So, absolutely fine, Yogesh. It is a CRVO. Okay. So, what has happened is there is neovascularization of iris, and this has caused a neovascular glaucoma. Okay, and this neovascular glaucoma is usually seen after 3 months in which disease? CRVO. So that's why it is also called 90-day glaucoma or a 100-day glaucoma. Now let's see other options. Retinal detachment. Okay, retinal detachment won't come with the high IOP. Acute uveitis, yes, this patient may have an acute uveitis, but remember, in acute uveitis you won't see such clear cornea and such blood vessels on the iris. Yes, chronic uveitis can cause a neovascularization of iris, but not acute uveitis. CRAO also does not present with the neovascularization very commonly. In very rare cases, it can present with a neovascularization. So the answer here is CRVO, that is the central retinal venous occlusion, which can cause a 100-day glaucoma. Okay, the next thing is, the next question, follow-up question is, not a management option in this condition. Glaucoma drainage device, IV mannitol, pan-retinal photocoagulation, or Ozuridex. So absolutely fine, Neelu. This is the 100-day glaucoma. Spot on. So try to answer. So our answer here is Ozuridex. Okay. So remember, the Ozuridex, which is a dexamethasone implant, okay, is not used in the cases of neovascular glaucoma. Okay. Yes, dexamethasone implant can be used in the macular edema that is caused. Okay. So it can be used in the macular edema, but not in your cases of neovascular glaucoma, because this dexamethasone implant can paradoxically cause a more rise in intraocular pressure. So the answer here is D. So you would ask, sir, how to manage this type of neovascular glaucoma? Okay, so first of all is that why the neovascular glaucoma occurs? Because this neovascularization, which has occurred because of the VEGF secretion, it can basically go up to the angles and cause creeping angle closure and the inability of the aqueous humor to get drained. Okay, so that's why a neovascular glaucoma occurs. What are the causes? The causes are chronically raised intraocular pressure, proliferative diabetic retinopathy, central retinal venous occlusion, which is also called 100-day glaucoma, ocular ischemic syndrome, and intraocular tumors. Okay, so there are thousands of causes. Out of them, for the NEET exam, these causes are most important for you. Okay, And what is the treatment? Remember, the first treatment that you do in the cases of NVI is that you do a pan-retinal photocoagulation. Okay, the reason is that the main cause of glaucoma in these cases is not just an IOP elevation, but because of these new vessels which have caused the outflow obstruction. Okay, so first thing is you have to reduce the formation of this new vessels. And how you do it? How to decrease it? You have to decrease the VEGF formation. Okay, so first you do a pan-retinal photocoagulation, avoid and break and photocoagulate the cells that are producing VEGF. Then you can use anti-VEGF injections like ranibizumab or your bevacizumab. Okay, if the IOP does not control even then, go for trabeculectomy. But the problem with the plain trabeculectomy is that it usually gets failed because of the intense fibrosis. So here you can use antimitotics, and the most common antimitotics that is used with trabeculectomy is mitomycin C. If that also fails, then you can go with the glaucoma drainage devices. And the most important glaucoma drainage device that we use is Ahmad glaucoma valve. Nowadays, a new valve that is called Adi valve, that is AADI. So this is an indigenous valve that is produced by the manufactured by the Arvind Eye Institute, and this is also used for the management of these complex type of neovascular glaucoma. Okay. Okay, the next question for you is, which of the following is not true regarding steroid induced glaucoma? So type of an open angle glaucoma, high myopia is a risk factor, stopping the steroid can cause decrease in intraocular pressure, dexamethasone is a soft steroid. Try to answer quickly. So the answer here is D. So remember, the dexamethasone is not a soft steroid. It has a very high predisposition to cause steroid induced glaucoma. Okay, so it is a hard steroid and not a soft steroid. Okay, so remember, steroid induced glaucoma is an open angle glaucoma, high myopia is a generalized risk factor, and stopping the steroid can cause decrease in intraocular pressure. Okay, so few more important points regarding the steroid induced glaucoma. Remember, the topical steroids have more predisposition. Okay, so the topical steroids cause glaucoma more, and the systemic steroids cause posterior subcapsular more. This does not mean that the systemic steroids cannot cause glaucoma. Any systemic steroids, your inhalers, your skin ointments, they can also cause a glaucoma, but the predisposition or the risk factor is low. It is a type of open angle glaucoma, and the mutation in tiger gene or myosin gene is responsible for it. And the basic pathogenesis is that it basically stabilizes the lysosomes, so the outflow mechanism obstruction occurs in steroid induced glaucoma. There is no pupillary block there. Okay, this is called a steroid induced open angle glaucoma. Okay, so what are the risk factors? The risk factors I told you is high myopia, a patient who is already a primary open angle glaucoma or a normal tension glaucoma, African race, trauma, and pseudoexfoliation. There are many risk factors. Out of these, I think these are important for you for the exams. Then we have either soft steroids or hard steroids. So what are the soft steroids? So soft steroids has low predisposition to cause glaucoma. Okay, so they have less risk, and The hard steroids like dexamethasone, prednisolone, difluprednate, these have high risk to cause these have high risk to cause the rise in intraocular pressure. Any doubts, anyone till now? Okay, so what is the treatment management? So the treatment is, the first thing that we do is that we stop the steroids. If the patient has just got high IOP but not any optic nerve defect, then just stopping of steroid can do the treatment. But if he had already got an optic nerve defect, then you have to start the anti-glaucoma medications. And if the damage is so much that it is not controlled even by the medication, then you have to go for the surgery also. Okay, so these are the management options of the steroid induced glaucoma. But first and the foremost thing is stop the steroids. Okay, the next thing is about the lens induced glaucoma. So a patient presented with very high intraocular pressure, with hypermature cataract, with open angle glaucoma, with uveitis. Okay, so I repeat it once again. The patient has high intraocular pressure, hypermature cataract, with open angles, with uveitis. So what is your most probable diagnosis? Phacomorphic glaucoma, phacolytic glaucoma, steroid induced glaucoma, or absolute glaucoma? Try to answer. So yes, the answer here is B, that is the phacolytic glaucoma. Okay, phaco means lens, lytic means that there is a uveitis component that has come, and this basically causes a open angle glaucoma. Okay, so the answer here is phacolytic glaucoma. There is no mention of steroid use here. This cannot be a steroid induced glaucoma. Plus, in steroid induced glaucoma, there is no uveitis. Okay, so that is totally not relevant here. Absolute glaucoma usually occur in angle closure glaucomas, but remember, a absolute glaucoma would present like a painful blind eye. Okay, here there is no mention of a blind eye, there is just a hypermature cataract. Okay, the phacomorphic glaucoma can also present like this, but here there is a angle closure glaucoma. Okay, so it is not a phacomorphic glaucoma. Okay, so few important points regarding the lens induced glaucoma. So remember, a phacomorphic glaucoma is a secondary angle closure glaucoma. What happens is that your lens increases in size. The lens becomes intumescent. Okay, and this intumescent lens basically causes the angle closure. So this is a secondary angle closure glaucoma. Okay, so Dr. Mohini, an untreated primary angle closure glaucoma who has undergone attacks of acute congestive glaucoma, they are the most common cause of absolute glaucoma. Okay, so the second thing is phacoanaphylactic glaucoma and phacolytic glaucoma. These are two important points. So how to differentiate between the phacoanaphylactic and phacolytic glaucoma? In phacoanaphylactic glaucoma, remember the lens is a cryptic antigen. Okay, so it can produce an inflammation, but it is bounded by the capsules. So let's say by a trauma, okay, or during a cataract surgery, we have removed the capsule. So after the capsule is removed, this lens particle can come into the anterior chamber. Okay, and it can basically cause instant uveitis there. This is called a phacoanaphylactic glaucoma. You all get my point? What is phacoanaphylactic glaucoma? That the lens capsule has ruptured That's why the cryptic lens antigens, which were earlier enclosed by the lens capsule, they come into the anterior chamber and cause uveitis. This is called phacoanaphylactic glaucoma. Now, what is phacolytic glaucoma? Phacolytic glaucoma means that, let's say there is a hypermature senile cataract which is Morgagnian in nature. Okay, because of such a hypermature cataract, it has caused some micropores in the lens capsule. Not because of any trauma, but because of the aging process, this micropores has happened, and these micropores have caused the antigens to go in the anterior chamber and slowly and steadily cause a uveitis. Okay, so this is a phacolytic glaucoma. So the pathogenesis remains the same. Only difference is the rupture of the capsule that does not take place in a phacolytic glaucoma. And both of them are a type of open angle glaucoma. Okay, so they are secondary open angle glaucomas. All of you, Dipanshu, Mohini, Neelu, Mohini, Sombir, you get the point. What is the difference between the phacoanaphylactic and phacolytic? So phacomorphic is secondary angle closure, and the phacoanaphylactic and phacolytic are the secondary open angle glaucoma. Okay. Now remember another term, that is microspherophakia, or sometimes what happens is due to trauma, or let's say a disease like Weilmach-Chesney syndrome, this lens can go in the anterior chamber and cause a angle closure there. Okay, so this is called a secondary angle closure glaucoma because of the displaced lens, maybe because of a condition which is called microspherophakia, or maybe because of any cause of lens dislocation in anterior chamber. So my options A and D, they are angle closure glaucoma, and my options B and C are secondary open angle glaucoma. Okay, now one question they can also ask is how to treat a lens induced glaucoma. So remember, whenever they ask how to treat lens induced glaucoma, you do not have to do a filtering surgery. So in options B and option C, what you do is that you just control the uveitis with, let's say, topical steroids and do a cataract surgery. Okay, so in B and C, just give steroids and do a cataract surgery. In phacomorphic glaucoma, what you can do is that you can basically give the patient IV mannitol, decrease the IOP, and do the cataract surgery. So the ultimate treatment modality in any of these type of glaucoma is not glaucoma surgery but the cataract surgery after decreasing the intraocular pressure. So now would you answer the questions? Any questions regarding the secondary glaucomas? Any doubts, anyone in this session? Okay, so thank you very much for attending this session. This is my referral code, Vineet Sehgal at RPC Ames 4415. Just you can log into the Unacademy, subscribe for the Unacademy with this code. Thank you very much and all the best.